Sure. So Dan is an ex-particle theorist, as some of you just heard, that we met at the University of Manchester when he was doing his PhD there. But since then, he's been working more in the data science field and doing public health at the University of Southampton, and now has been drawn into helping with some modeling for COVID-19. So he's going to tell us about what he's doing there.
And drawn is certainly the right word. Okay, so thank you for having me, everyone. So I'm Dan. As we've just heard, I do work in data science, particularly in machine learning and predictive analytics. But today I'm going to be talking to you about the work I've been doing with regards to modeling the COVID-19 epidemic and its impact on hospitals specifically. So this project, it was initiated by a collaboration between the University of Southampton and our local trust, which is the University Hospital Southampton Foundation Trust. We also are working with the Applied Research Collaboration, the NIHR Applied Research Collaboration, and the Academic Health Science Network in Wessex. So just to start off, if it'll work, there we go. So just as a quick outline, I'm sure this problem needs no motivation, but I will try my best to motivate it from the sort of perspective of the hospitals, and then sort of come up with a problem statement that the hospital came to us with 7 or 8 weeks ago. Then we'll talk about how the model has been developed, and it's a colourful story. And then finishing with where we're currently at and talking about where we're going to go next. So, as some of you may know, COVID-19 has caused a lot of death across the world. And what is not known is that is causing quite a burden on hospitals, particularly in high density areas. The expectation back 7 or 8 weeks ago was that Imperial College were producing these predictions that the UK would have nearly 500,000 deaths if nothing was done. So there was an expectation that a lot of hospitalizations was going to occur all at one time, and it was going to overload the health system. And an overloaded health system is quite bad, and it could cause a lot more death. So basically, there were some very severe issues, particularly with our local hospital. They had no way of estimating the COVID-19 demand on them, for a start. Not even an Excel spreadsheet. They just had no idea. All they were told was basically, just expect a lot, which is not very good, really. So we decided we'd step in and help with that. In addition to that, there was no way of estimating social distancing policies, and there was no estimates of things like the ICU usage, and in particular ventilator usage, which was a bigger concern at that time. In the case that the hospital would be overloaded, there was a need to try and plan for the number of people in excess of the capacity of the hospital. So that this is talking about things like setting up field hospitals and hiring extra staff and volunteers. And although at the moment it is currently in decline due to social distancing policies, there are current fears that there will be second waves that occurred in a similar fashion to the 1918 epidemic. Pandemic, sorry. So the problem statement really, as the hospital came to us, they said that we need some assessment of the demand on our resources from a bed's point of view. So this is the assessment of the number of general ward beds, the ICU beds, and potentially assessing how many people will die for the mortuary staff to be able to cope with it. The resources, they were hoping that it would be broken down by age group as well. So maybe they could implement, if in the desperate scenarios, age-based policies on care. There was also, So we require a model to try and predict the hospitalizations as a function of time. And what this has to reflect is the transmission dynamics of COVID-19, and it must take into account the observed data. So we needed a pipeline which took in data from the hospital, produced predictions, and then output some scenarios, shall we say, so that the hospital staff can make some planning decisions. So on the right-hand side here, we've got some remarks. A lot of classical models do not explicitly include hospital pathways, so you have to take that into account. Usually, from what I saw when we were initially doing this 7 weeks ago, there was no, it was always just a rescaling of the infections curve. And that's not really a good way to do things for the most part. Most importantly, actually, hospitalization length of stay distributions, they are not exponential. So you may or may not know that the exponential distribution is a memoryless distribution. And usually in these scenarios, when you code the SIR model, it's memoryless. So there's a sort of technical problem to be solved there. You know, how do you introduce this sort of memory into the simulation? There's also no solid knowledge of when the first UK case was. So this is something that you have to try and fit to. And by far the most important thing is the number of cases cannot be used reliably to assess infection rates. And I'll go into that later on. So we start our journey of this model development. And as you can see, we started out with a tool that was developed by Penn State about 7 weeks ago, actually, called Penn Chime, which essentially implements a deterministic discrete time SIR model. The reason why we went for a tool like this was because at the time we had the hospital, they needed answers and they needed them quickly. There was fears that their capacity was going to be breached in 3 weeks. So they needed something quick and an approximate number to start planning to. So we found this tool. We essentially looked into it and determined that actually the hospitalization time series that they were producing were just simply a rescaling and a shifting of the infection curve. It also included, quite neatly, a social distancing parameter. So that means after a certain point, the number of contacts is reduced by a certain percentage. As you can see in that graph on the right hand side, that is what is happening there. You kind of get this almost exponential growth, and then all of a sudden there's a shock to the number of contacts. It's quite a strange graph, actually. I'm not sure the implementation is clean there, but anyway, so we use this in the early stages to produce an approximate forecast for the peak of the epidemic. However, as it became apparent, there are a lot of issues. So the beta parameter in the SIR model, which is this number of transmissions per day, is calculated via a doubling time, which is only really effective at the start of the epidemic. So that was a bad thing. You can only ever model one social distancing policy. In the UK, there has been 3 so far that major changes from the government's perspective. So we being able to only model one was quite bad. And we couldn't fit the model or integrate the software easily with our systems, so it made that quite difficult. So essentially, we used it initially to produce some very rough numbers, and then we dropped it. And decided that we would go on our own way and try to develop a model in which contains and treats properly the hospitalizations and the deaths and things like that. So that brings us on to the Schauder model. So there's a need to expand the SIR model to include more states. So for example, there's a more realistic pathway in hospitals. So for example, if you go into hospital, you're quite likely to, you're most likely to either recover and leave the hospital, or you go to the ICU. When you're in the ICU, you don't generally directly recover from ICU. You either come out of ICU into a general ward, or you die. And then once you're in the general wards again, you are most likely to recover. So this on the right hand side here is the state diagram, which illustrates that. Hopefully that is clear. So this is just it's a deterministic discrete time model, like the Penchime model that I just described to you. Except the equations are a little more complicated, but it's not too bad. I wouldn't get too daunted by the notation and the maths here. All this represents is the changes of the proportion of individuals in each state depends on a few things, like how long they're in the state and whether they actually change that to a different state. So there's these gamma parameters which cover it's the reciprocal of the average time it takes to go from one state to another, and then you've got the proportion of the population parameters. So beta here, strictly, it is actually a function of time. Oh, by the way, I should say, feel free to interrupt me at any point. I'm happy to take those interruptions if there are any urgent questions. But yes, sorry, I'll continue. So beta is a function of time in this case, because when when government announce interventions that affects beta in some way or another, generally a good approximation is to just assume that it's a constant reduction from the point that they announce it, or maybe with some delay so that the public can react and adapt to the new rules.
And I actually have a question. I mean, for people to go to intensive care, I mean that's usually according to the press, it takes a week, and then on average, and then people suddenly go there. So there are also some of these non-Gaussian processes involved. I mean, how do you model this in here, or is this just?
So that's a good question. Here, this is still assuming an exponential distribution, because these are all that's what you get when you so these come from continuous time Markov chains, essentially, which is all exponential in that case. So the non-Gaussianity, yes, I agree. This model does not take that into account at the moment, but as you'll see, we include that later. Is that okay?
Yeah.
Yeah. Okay. Right. I'll continue. So, so we implemented this model in Python, and we made it so that the parameters that you put into that model are human parsable parameters. So instead of having to put in beta and the gamma parameters, you use things like the average time in state, the R0 at the start of the epidemic, and these proportion parameters map quite nicely. So instead of a potential user having to do that extra step of thinking, you can just put these things in straight away. The use case for this model is you simulate at a region level. And the reason why you simulate at a region level is because you want to, it's not too big and it's not too small. So if I wanted to, so I want to model the hospitalizations at my specific hospital, I have to take into account the fact that if it's too small, there's going to be people who are infected coming into my population, and that's the shadow model doesn't take that into account. Whereas if it's just right, so to speak, those effects are small enough that it doesn't matter for the overall prediction. So that's why we chose a regional level model over a UK-wide or a Europe-wide model. There's certainly Europe-wide is out of the question. Yes, so the as I've just said, the R0 is one of the more prominent parameters. This is estimated actually from the data, as you'll see later. We don't make any assumptions about what that could be. We just fit it to the data. I'll move on. So the fitting and projection scenario that we had actually with the hospital. So the hospital are interested in various scenarios, and in particular, the UK has been in lockdown now for 6 weeks or so. There's a real fear now that people are starting to become more relaxed with social distancing rules. So the question was asked, if can we model this effect? It's called behavioral fatigue. So this was asked about a week ago. So we did that scenario, and I'm showing you that scenario today. So suppose we're interested in the effect of some new social distancing policy, either it being some natural reduction in social distancing, or whether it's some stricter enforcement of current rules, because we don't know what the government is going to announce and things like that. So this must be conducted in addition to the policies that have already been disseminated. So in short, to evaluate this, what we do is we fit the hospitalizations curve, not the case numbers, to previous data, and then we have to make sure we correctly implement the past social distancing factors, and then vary the social distancing factor for the last policy to show the spread, the possible projections. So fitting the infections curve, as I said before, is ill-advised. And the reason why that is because the availability of tests really varies with time. And who can take the test also varies with time. So for example, in the UK, there is a policy, only key workers at the moment can really take a test, amongst other things. But there was a lot of confusion towards the start. There was an announcement by the government saying that we all had to, if we all started coughing or had a fever, you had to stay indoors for 7 days. and basically tell no one, which was not particularly useful. So the idea that you could use case numbers, it rapidly diminished. And for all of those reasons, we think that the signal to noise ratio was just very low and probably likely not very usable at all.
Can I ask a question there? Because the data-rich environment would be testing, right?
Yes.
Technically, how to do that is maybe a separate question, and appears to be technically a significant challenge. But that seems to be the goal. Is that somehow integrated into the UK policy as a goal?
It's slowly getting there. There's been a reluctance here in the UK to do that for whatever reason. I've always been of the opinion that you should be testing and doing contact tracing and these kinds of things. But alas, it's not really materialized. I think that they're starting to wake up to the fact that that needs to be done to try and prevent secondary waves. But I mean, that's my opinion.
But because I mean, what you called out is precisely the weak point, is that if you understand this very well, then you're South Korea, or you can control it, but it's also, you can predict what's going to happen if there's low latency mass testing available. I mean, I'm sorry I interrupted you. You're talking. You're going to go on and we'll talk more about what you do in the absence of information about the infections curve. But it's clearly, if that's more reliable, it's clearly makes the modeling easier, right?
Yes, indeed. There's another important point, and I'll continue with the talk now because this is going to answer the question. And that is that things like hospitalizations, ICU usage, and deaths are actually more reliable for fitting anyway. That's primarily because these are clinically guided situations. So patients are more rigorously tested. Their temperature is taken by a professional, and they can recognize if it's a dry cough or a not dry cough. These kinds of things. So that it's a lot more credible data, in short, and it's more likely that indeed COVID-19 hospitalizations is probably a percentage of the infections, because there's going to be a fixed number of people in your region, roughly, especially under lockdown rules, and there's going to be a percentage of people who are more likely to be hospitalized than others.
Please continue with the talk. I have questions at the end, but please continue.
Okay. So for this scenario, we received data from the University Hospital Southampton Trust, and they give us the number of COVID-19 hospitalizations each day, and that's not only is it the total people who are in beds, it'll be things like the daily admissions, the discharges as well. They also give us the number of ICU beds used for COVID-19. In addition to that as well, they give us the number of ventilators that are in use, mechanical ventilators, but we don't fit that at the moment. That wasn't a request from them. This could be used then naturally to fit it to some curve that we produce by the Schauder model. So for internal hospital states, because I mean, as I said previously, there were 7 gamma parameters, 3 proportion parameters, and beta has a few hidden parameters within it because there are at least 3 or 4 social distancing policies. So that's a lot of parameters to fit to one time series. So it's good to try and regularize that in some way. And the way we do regularization at the moment in particular is not really a good way, but we take data from publicly available sources like something called the ICNARC report, which summarizes the length of stay of COVID-19 patients in ICU beds, etc., etc. So we can fix some parameters from that, and then leave things like the R0, the average time from infection to recovery, and the average time from infection to hospitalization free. So we can fit to those parameters. Of course, as well, the date of first hospitalization is largely unknown. I mean, at the time, people might have been coming in for things that are related to COVID, but they didn't know they had COVID. And there's all these kinds of possibilities before it really hit the UK. So this is an example of one scenario that we fitted. So the black line here is, I know the experimentalists amongst you are probably thinking, well, the confidence intervals, but we'll get to that in a moment. So the black lines here are the time series as observed from the hospital. And the curve, the red curve, is our predictive curve from the shadow model, as we expected. And the pink curve is the predicted curve for the ICU time series. As you can see, it matches up reasonably well, except for in the middle where it seems to underestimate and towards the end where it overestimates. But I can go into reasons why I think that is happening a little later. So what's quite important about this graph is that towards the end, you'll see these sort of bands appear. This is to reflect the change in the social distancing policy towards the end. So for the last policy, we change it in the cyan region, plus or minus 15% reduction or increase in social distancing. And to make it a bit more clear, what could happen is that, you know, it could go back up and come back down again in those circumstances, or we could see a nice neat exponential decay on the other side of the scenario. Okay, so that's just some nice things. So regarding the confidence intervals, I didn't really emphasize this at the beginning, but this was very much a business-like project to start with. It wasn't academic. So it was a lot of, we need answers by Monday sorts of scenarios. So we ended up having to work in a very agile way. And consequently, there are some things that should be there, but aren't. But we're working to improve these things, and I'm aware of a lot of things that are wrong that need to be implemented. So that's the reason why we haven't got it yet. Okay, so there's lots of uncertainty here. I know I said that the number of cases had its uncertainties, but so do the hospitalizations, because there are potential coding errors between people being listed on the system as suspected versus them actually having COVID. Because it's a new disease, it's quite it's a new technique to adopt by staff. So consequently, there's that extra effect that, you know, things are not being recorded properly. And these are more like random errors than systematics. There are changes in the way COVID-19 hospitalizations are reported. I've not got too much information on that at the moment, but we think that there are some changes in requirements, or the inclusion or exclusion of certain conditions can change that. So that would result in a systematic error, so either under-reporting or over-reporting consistently. And then you've got things like the weekend effect. You know, the people are less likely to report things in a timely fashion in certain scenarios, like at the weekend. So in terms of the fitting as well, I mean, we're just using a bog standard gradient descent algorithm for it, meaning we could end up in a local minimum. And you know, there's this type of regularization. I mean, we regularize by basically fixing certain parameters according to publicly available data, which is not the best thing. It's better to use things like L1 regularization, or you know, these kinds of things that you would normally look into. So, yes. Anyway, so now we come on to the shortcomings of this new model. For example, there's no social resolution. So it still assumes that each individual across the region has an equal probability of interaction, but that's not necessarily true. I mean, somebody in one part of the region may never reach another part of the region because maybe they don't travel much or something. So there's the key there is to try and introduce some kind of network into the simulation. And networks are quite important, I think, here. So I'll go into that a bit later. But the solution to that particular bullet point is that we can use an individual-based simulation instead of this aggregated view. So we can assign attributes to individuals based on their demographics. So that's things like age, or maybe even where they live and their deprivation index of their streets and things like that. Or you can start to look at these social interaction networks. It also doesn't represent the non-exponential distributions of length of stay. So for example, the length of stay in a hospital, I know for a fact, is typically gamma distributed. It's not exponentially distributed, and gammas look quite different in general. So the way that we can do that is we can say that each individual has a different sampled length of stay from some non-exponential distribution. And by far the most important thing is a deterministic simulation, which means there's no variance, assessment of the variance at each point, which means that we need to, you know, make it stochastic essentially. And that'll make the fitting a lot easier as well, or a lot more robust, shall I say. Okay, so now we move on to where we are now. This is currently still a work in progress, I should note, but essentially what we have instead is a Monte Carlo simulation of synthetic individuals interacting in various networks. So this model is based on two parts, an allocation model, so how individuals are assigned to different contact networks, and a transmission model, which is, as we've seen, is the usual SIR type approach. So this simulation could include different probabilities for different disease-related outcomes. You can also include things like super spreaders and all manners of things that you might think of when you start thinking about epidemics. And then you can incorporate the known distributions of incubation periods and things that you could generally get from data. So why look into networks? I mean, for the most part, maybe it's an unnecessary complication. As you saw before, you know, we've already got a curve that fits quite nicely. So why do we want to include networks? Well, first of all, UK government interventions, they're based currently on out of household contact rates, So that's the closure of things like schools, workplaces, restaurants, pubs. There's also controlled entry and enforcement of social distancing in supermarkets, and generally the government are saying that you can only travel for essentials, so going to the supermarket or to go to work if you're an essential worker. So we need to estimate the effects of easing various aspects of these lockdown policies. So in particular, you know, I'm hearing some rumours, but there's going to be an announcement on Sunday, actually, in the UK for a timeline for reducing lockdown policies, or just easing the lockdown policies. So there's rumours that there might be an allowing of non-essential travel. So that's, you know, maybe going out for extensive walks in the community, going to sit in parks and these kinds of things. And there's also rumours of schools reopening at the start of June. And there's also rumours of the partial reopening of some non-essential workplaces like restaurants and pubs, where people can only sit outside, they can't go inside. So there's all these kind of reasons why you want to start trying to include sort of these social spaces into your model. And the best way to do that is via networks. So I won't dwell on this too much, but essentially in this model, it's a little different perspective from the typical network epidemiology field, and that is because we assign individuals to networks as opposed to assigning individuals to other individuals. All right, so that's a subtle difference, but it results in the same thing, and it allows us to be able to control the contacts in a social space. So in short, individuals interact in fixed networks. Each individual has an equal chance of interaction with other individuals in their respective networks. We assume that the individual's disease progression is unaffected by other individuals in those networks. So that's just saying that your body reacts to COVID-19 in a specific way that is not influenced by the presence of other people with COVID-19. And there's some other assumptions, but I'm not going to go too much into that. The allocation model, as it stands, we don't really have one at the moment, but it should be based on things like sociology data, so things like the census in the UK, and things like labour statistics and all these kinds of things, where we understand the distribution of people who are working and where they work and which workplaces, you know, the size of workplaces and size of schools and these kinds of things. So in terms of the possibilities, there's a lot of possibilities for using this allocation model. So there's you kind of explicitly model these high person density areas. You can have a location-based network where essentially instead of you have one people in one sort of region, they all interact with each other in one way, and then they interact with people in adjacent regions in a different way, and you can have this kind of neighbor effect. But as I said, you know, we're at the stage where we're about to start developing this, so we haven't really got anything to show there. In terms of the transmission model, so the probability of an infection for an individual is given by this formula. So this is essentially the CDF of an exponential distribution, assuming that the rate is given by this kind of sum inside the exponential, so that that sum is just a sum over the networks that the individual is in, and the beta parameters are the usual contact rate parameters, and the ij of t here is the number of infective people at time t in that network. So after an individual gets infected, their individual timeline is unaffected by the presence of other individuals, which gives us the freedom to then say, to sample from non-exponential distributions for those people. So things like the infectious period, I know for a fact, is not exponential as well. It's gamma distributed. Survival from infection to death as well is more likely to be a viable distribution. Then all these kinds of things. But yes, so we have the freedom to do all that. Then what we do at each time step, actually, we aggregate those timelines to make it computationally less expensive. I mean, imagine trying to simulate 2 million individuals in a region. That can be quite extensive if you don't have access to distributed computing resources. So we simply aggregate that as we go. And then once we've got multiple of these kinds of trajectories, we can then start to think about fitting that via maximum likelihood framework. So we basically assume that it's a black box and say, oh, there's some probability coming from these simulations of number of hospitalizations being 100 at this time point. Then we do it like that. That essentially is it for our journey, because we've got that implemented. We are going to be making that public, I believe, at some point. So I'm happy to share that once that is around. But in terms of future directions, there's a lot of obvious directions that need to be undertaken. So, for example, the building of this allocation model, which is going to be quite a sizable effort, actually. Trying to generate a set of individuals that satisfy a lot of these distributions is going to be quite difficult. Also, I should note as well, when I presented that probability to you here, I assume a constant survival rate at time t, which is not necessarily true. I mean, in a continuous time Markov chain, the inter-event time is exponentially distributed, but not necessarily the integrated time over a time step. So this is like an approximation to the dynamics. So really what we want to see is the influence of changing this time step on the dynamics and seeing whether it does actually change the average curve that much and these kinds of things. So in terms of the network-based directions, there's a lot of things in network epidemiology concerning results concerning the degree distribution on the possible interactions between individuals. So it'd be interesting to see if we can add that to the social spaces. So for example, there might be different degree distributions for schools as opposed to workplaces, which could change the dynamics a little bit. And then there's also possibilities like, well, what if we simulate children sitting in a classroom and going out to play at break time and these kinds of things, and can we get an idea for the number of contacts per day if we try and simulate that? But yeah, sorry, I've gone on quite enough. But that's the end of my talk. Thank you very much.
So that was great, Dan. Thank you. Questions or comments from ideas from others? Don't be shy.
Very generic one. Is there data that we talked about testing data, but are there other sorts of sort of missing information or inaccurate information that would help modeling a lot in your experience?
Well, what do you mean by that? So I guess knowledge of the amount of deaths, for example, might be quite useful. I know for a fact that Public Health England, they publish death statistics by region and actually by individual hospital in some cases. So that's one avenue to look at. Deaths are quite slightly different to hospitalizations, I would say, because the subject is dead. So there's a need for an autopsy to be done. That can take some time, and I don't know whether it is as accurate as hospitalizations, but it's still more accurate than.
So you're talking about deaths that occur outside of hospital in this case.
Yes. So yes, pretty much.
Yeah. Okay. Yeah, that's what I was trying to get at.
Yeah, so there's that. I mean, in this particular case, I am trying to just predict the deaths coming from the hospital so that the mortuary there can prepare for. Oh, it's quite depressing to think, but yes.
So maybe an additional question, it's not unlikely that there will be a second wave. I was looking, for example, at the plan for opening things in the Netherlands, which also is a sort of testing poor kind of place. And, basically it aims to have everything open by the 1st of September, which sort of begs the question, does that mean the second wave begins on the 1st of October, right?
Yeah.
So, but okay, maybe that's how it's going to play out. We'll see. But what that means is that there is some time now. There was this initial reaction, as you said, which was, imagining the worst case scenarios and, the social distancing that was put in the various countries and the lockdowns curtailed that, and that's great. But now steadily reopening, it's not unlikely that there'll be a second wave. So the question then is, how in the next months do we prepare to model that much better? Not in
yes.
you said you were reacting. You were working with the hospital, and they were trying to immediately figure out the things by Monday. But so what do we do in the next months in terms of preparing for that?
So in terms of projecting the number of hospitalizations, so in this case, you can actually, as I, if I go back to the slide here. So in this scenario, we actually put in manually a new policy, right? So we said, right, this is going to happen on this date. Let's see the potential trajectories of the hospitalization curve, right? So when we start talking about second waves and things like that, we are mostly concerned with, so for example, I think maybe 5 or 10% of the UK population has been infected. That still leaves quite a large susceptible population. So this is why that can be the driving force for a second wave, because if you've got.
But the UK is still quite far away from that. I mean, if you take what the first surveys are taking, I mean, you're probably well below 10%, right?
Yes, exactly. And the lower that number, the worse the second wave could be.
Yeah. I mean, there is in the. In some of the discussions, I mean, people are. I mean, is your model able to also predict different types of outbreaks? Because I mean, several of these outbreaks which we saw in Germany or in which we saw also in the UK and in Sweden and so, were induced by these super spreader events like the one in Ischgl. While I mean in Germany there's a lot of discussion about a second wave where the pattern is different, because we will see a slow growth in the population at large, and then suddenly everywhere it's going to go exponentially. Is that something which your model could actually study and predict?
Yes, certainly. In fact, well, I mean, you can't really predict super spreader events. I should point out. You can certainly look at the effect of one in the model.
But I mean the second one where now I mean it's spread all over the population, and we leave it there undetected for some time, and then it rockets up. Right? I mean that's the fear of the second wave, which I think right now is what we should take serious, isn't it?
Yes, that's right. Yeah, 100% agreed. So what's the cause of a possible second wave? So we've got the fact that maybe lockdown is completely released, right? So in that case, it'll be back to exponential growth, and then we'll have to implement social distancing policies again after a certain point. Otherwise, I don't have any graphs here to show you, but if you assume that there's no lockdown policies, the number of hospitalizations is scary, to say the least. So there's that possibility. You can remove all social distancing policies and see what happens, and naturally what happens is it spreads like wildfire through the population, and you end up with this huge second wave. Alternatively, if you ease lockdown over a certain period, actually, there is another possibility as well. I mean, this is something that's become recently quite prominent, given the media the last couple of days in the UK. There's been talk of easing the lockdown, and the weather is also going to be very good in the UK, and British people, they need to get the sun where they can get it, So there's this kind of cultural effect where people ignore rules if it means that they can get a tan or whatever. So in that case, there could be a super spreader event coming up. And in that case, you just basically increase your beta parameter during that time to reflect that super spreader event. I mean, in reality, that's not the best way of doing it, because really what you want is some individuals who, they transmit the disease to many more people than the average person, and that's how you want to model it. And because that's what super spreading is, right? So there's in other words, the model can handle it, but it's not particularly in the best way as it stands.
Again, if one works backwards from the notion that there could be a second wave, right? That would be the worst case scenario, right? Mm-hmm. And it's potentially not so unlikely. How would we structure things such that the predictive data-rich capabilities of models for hospitals are much better positioned than they were coming into the current wave? So let me give you two ancillary questions, which is, you were focused in this study, you started with the Penn Medicine model, right? Mm-hmm. Separately, we're also working with Penn Medicine on other stuff. are you interacting with them about how they're evolving their models? Is there some sort of UK structure to, you know, not take what you're doing again for next Monday, but sort of build that into a national infrastructure for modeling? So in the UK, for example, and it was actually quite impactful in the US, there's the IC group, right?
Yeah.
That was doing sort of, you know, big picture modeling of, you know, the societal impact. And independent from the technical aspects of what they did, it certainly had a big policy impact, right? Both in the,
Yes.
the UK and the US. So is there some sort of, you know, collaborative structure that is bringing together your efforts and their efforts and you know, presumably other efforts in the UK and you know, and abroad to prepare
Yes.
for a better modeling that's not for next Monday?
Yes, I understand. So there is progress in that domain. I would say I'm in our team's in our little corner at the moment. We're only dealing with Southampton Trust, but I mean we are engaging with other trusts and other universities, trying to build this national effort, because, as you say, you know, we don't want people building these models, you know, in isolation, especially when one of them or one or two of them could be very good to predict the hospitalizations, you know, nationwide. So the collaborative infrastructure is quite it's quite complicated, because I mean, typically in academic spaces, academics work very differently to the way most hospitals want them to work, as I've found out. So there's this idea that you need to move in a more agile way. You're not writing papers, you're trying to improve your predictions instead, for the most part. So I found that actually in that sense, getting people on board is quite difficult, because I don't know how else to explain it, really. But
that's clear. It's clear they have, you know, hospitals are both a business and ICU. We have people in front of us situation, right? So the time scale can be extremely immediate, but
yes,
a not unlikely way that this will play out, again, looking at 1918 and again, today I was looking at the Dutch plan for how things will evolve, is that there could be, you know, the like your curves here, things could go down in the next month, and then there could be an explosion in 3 or 4 months. So the question becomes, which is non-technical, in a collaborative sense, how do we build up something that can be much more predictive of what's going to happen, given that there may be a breather period, not to use the funny word, no pun intended,
yeah,
of a few months to actually sort of develop the infrastructure, the academic infrastructure, not the React by Monday infrastructure, which once you have an academic infrastructure, the React by, which is properly constructed, the React by Monday part becomes more effective, right?
yes, exactly. And it's just how do I answer this? It's I guess one of the first steps is figuring out how to collaborate, right? That's a very big question, actually. I mean, model development, certainly you need to have some infrastructure there or some flexibility within your model, to have one group working on one aspect of the problem, and another group acting on another aspect. Or maybe the solution is that everybody does build their own model and it gets put into an ensemble of some sort, and it produces predictions from all the models, and you choose the best one based on some criteria. These kinds of sort of questions that need to be answered. These questions are beginning to be asked at a national level, I think, at the moment.
So, so how are the in the UK? I mean, it's clear that the IC-led group has had really an outsized, and important, because it, I think, actually convinced the political class to implement social lockdowns and social distancing. But so who are the players in the UK, for example, in terms of these kinds of epidemiological modeling of? Because you're acting locally in some sense, right?
Yes.
But presumably the others that are doing the same, and then again, the IC group has had a policy impact, and so what is the state of play in terms of who's doing? Do you have an idea?
We know for certain that there's at least one other group who's very similar to us, doing very similar things in a different region. So we have been talking to them about collaboration, and especially collaborating on possible models. There is an initiative at the moment in the UK called the RAMP Initiative, which I can't remember what it stands for. Rapid Associate something mundane, I feel, but essentially it's a collaboration that's being put together by operational researchers who are essentially trying to stop other operational researchers from building their own models and trying to focus on one. So I don't think they have one central methodology yet, and I think that they're still recruiting people. But there's so many aspects to this problem that people want to cover, and I think that it's just about finding that way of connecting them all together that is just so key, that is not there. And I should point out that Imperial College, they do deliver a policy impact. However, as we've seen, they only released the code for their simulator about a week ago.
Yeah.
But I mean,
that's why I said they've had policy impact. But yeah, so this is precisely the interesting question, whether there's, so in this context, particle physics experimentalists deal in very large collaborations, right? So that's of course something we're always interested in, how to enable those, and it's clear that in terms of societal impact, that's something that could be quite useful here. How to make data-rich, sophisticated models, right, for any potential second wave, right? So. Okay. Other questions?
So just following up on that a little bit, what is the plan is this code going to be made public somewhere for your model? Do you have plans for that yet?
Yes, we are planning on cleaning up a little bit and putting it on GitHub. At the moment, it sort of integrates a few different things. So there's the model generation in of itself, and that's mixed with a fitting software. So it's all written in Python. So if you're a Python programmer, you can have a look at the source code. And to be honest, I don't know whether we'll open it for contributions. I mean, we're only a small team at the moment, but if I'll have to talk to my team about whether that's possible or not. But in reality, there's a lot of work to be done on this from this point forward. And I mean, if you're technically minded and are willing to help, I'd please let me know.
So do you know, are there conferences or workshops organized around this? So again, different communities have different community structure, right? And are there
Yes.
workshops, WHO organized, or whoever potentially could be the rallying point for things like this? It didn't sound like you didn't respond positively to any particular organization within the UK, but do you know, are there others that are focused on, again, the academic part that essentially should prepare the grounds for more nuanced modeling in any second wave? Are you aware of anything like that?
Yes, there is a conference that we've been targeting, I think, in Germany in September, where we're going to present, or hoping to present, a lot of this work. And it's an academic conference, so it will be much more robust by then. Given it's 4 months away. I think that we're in a much more relaxed period now than we were. So there's a bit of hope that we can get it written up and published in the usual channels. But there's a lot of specials on COVID-19, as you might imagine, and that's cross-field as well.
Specials in which sense?
Yeah, so special conferences specifically for COVID-19, not necessarily more general conferences.
Okay. Yeah, I mean, I think there's some, again, the thing that I see is that, the absolute best thing is we had a best of class, world vetted, academically detailed model that, is able to digest all of the data that can be provided, and a focus on making as data rich as possible by a few months from now, because if you sort of naively expect that there'll be the second wave at some point, because that would be a much better place to be in than where we are, where we've been in the past few months, right? So
yeah, certainly, yeah.
Okay, other questions? We're sort of at an hour and a half here. So Dan, this was great. Thank you very much for taking the time to prepare this presentation and talk to us.